All right, let's dive right into this essential explainer for all you MRCOG candidates out there. We're tackling RCOG Green-top Guideline 37b, the acute management of thromboembolic disease in pregnancy and the puerperium. If you're prepping for your exams, or honestly just want a rock-solid grasp on this potentially life-saving guideline, you are in the exact right place. We're going to break down this complex topic into clear, highly testable concepts using just the data we've got right here on screen. Let's get to it. To build a really clear mental framework for the exam, we will follow these 5 chronological phases of patient care: diagnosis of acute VTE, initial treatment strategies, ongoing maintenance therapy, managing labor and delivery, and finally, postnatal anticoagulation care. Okay, phase 1, diagnosis of acute VTE. Now, assessing deep venous thrombosis and pulmonary embolism in pregnant patients is, frankly, notoriously unreliable. The normal physiological changes of pregnancy totally mimic VTE symptoms. Think leg swelling, breathlessness. So the absolute crucial first step? Establishing if a patient with a suspected PE also has DVT symptoms. This entirely shifts your diagnostic pathway. If a pregnant woman comes in breathless, you absolutely must look at her legs. Why? Because finding a DVT indirectly confirms the PE. And since the treatment for both is exactly the same, spotting that DVT spares both the mother and the fetus from completely unnecessary radiation exposure from chest imaging. And that brings us to a massive 2015 update you've got to remember. Step 1, you do a compression duplex ultrasound. That's your primary diagnostic test here. Step 2, if it's positive, fantastic, continue the treatment you already started. But step 3 is the kicker. If that scan is negative, but your clinical suspicion is still high, you discontinue anticoagulants, but, and this is a big but, you do not discharge her. You bring her back for a repeat ultrasound on day 3 and again on day 7. What's super helpful here is how this visually maps out the exact diagnostic sequence you need to memorize, straight from the RCOG Guideline Appendix. It starts with clinical assessment, a chest X-ray, and an ECG. Basically, if there are no signs of a DVT, we rely on the chest X-ray to dictate our next imaging modality. It points you down the exact right path to safely confirm or rule out that pulmonary embolism. Now pay attention because this is massive for the MRCOG exam. Do not perform D-dimer testing or pre-test probability assessments in pregnancy, period. They have zero evidence base here and are absolute do not do's. You're definitely going to see this as a distractor in multiple choice questions. Remember, pregnancy naturally spikes D-dimer levels anyway, rendering the test completely useless for ruling out a clot. Just don't do it. So what if the chest X-ray is normal? Well, you have a choice to make between a VQ scan and a CTPA. You have to perfectly balance and explain these specific radiation risks to obtain informed consent. You tell the mother that the VQ scan carries a very slightly increased risk of childhood cancer. On the flip side, a CTPA is associated with a lower risk of maternal breast cancer compared to the VQ scan. Both absolute risks are tiny, but it's crucial for consent. Now, if that chest X-ray is abnormal, CTPA is always your preferred choice, hands down. Moving right along to phase 2, initial treatment strategies. Any woman with symptoms suggestive of VTE needs treatment commenced immediately. You do not wait around for scan results unless there's a strong contraindication. Low molecular weight heparin, or LMWH, is your absolute go-to. And as you can see here, whether you use enoxaparin or deltaparin, your initial dose must always be titrated against the woman's booking weight, or early pregnancy weight, never a standard adult dose. Oh, and the guideline notes there isn't enough evidence to favor once daily over twice daily dosing, which is why both options are listed for you. Here's a great little resource saver to keep in mind for the exam. Routine peak anti-XA activity monitoring is not recommended. You really only need to check it, specifically 3 hours post-injection, by the way, if the patient hits extreme weight criteria, meaning under 50 kilos or 90 kilos and above, or if she has complicating factors like renal impairment. Otherwise, skip it. Same goes for routine platelet count monitoring on LMWH. It's just not required. Now, while LMWH is your standard day-to-day treatment, what happens if you have a collapsed, shocked patient with a massive PE? That is a medical emergency requiring a multidisciplinary team. In that scenario, with cardiovascular compromise, intravenous unfractionated heparin, or UFH, becomes your preferred initial treatment. Why? Because it acts incredibly fast, and if you suddenly need to administer thrombolytics or do a surgical embolectomy, UFH can be quickly manipulated and reversed. Okay, let's transition to phase 3, ongoing maintenance therapy. Once your patient is stabilized, you're sending her home for the rest of her gestation. The golden rule here? Continue therapeutic doses of subcutaneous LMWH for the remainder of the pregnancy. You absolutely do not have the dose just because she's feeling better. The RCOG is very clear on this based on safety data. Maintain those full therapeutic doses, calculated by weight, all the way through to delivery. During this phase, teaching patients to safely self-inject LMWH and arranging for proper sharps disposal is a huge part of your job. Now listen closely to this next part. Vitamin K antagonists, like warfarin, are strictly contraindicated for antenatal VTE. They cross the placenta and cause fetal embryopathy, so they are a total no-go. What if she's allergic to heparin or gets heparin-induced thrombocytopenia? Well, under strict specialist advice, you might consider newer anticoagulants, but again, warfarin is completely off the table before birth. Next up is Phase 4, managing labor and delivery. This is the danger zone. It's the period of highest risk for both bleeding and clotting, so you have to nail these timelines for planned inductions or elective cesareans. Memorize these clinical anchors. 24 hours prior, discontinue LMWH maintenance therapy because of its long half-life. 12 hours prior, discontinue subcutaneous unfractionated heparin. And 6 hours prior, discontinue intravenous unfractionated heparin. Also, make sure to explicitly tell your patient that if she thinks she's going into spontaneous labor at home, she needs to stop injecting immediately. What if you have a patient at high risk of hemorrhage, say with an antepartum hemorrhage at term? If she still needs anticoagulation but the bleeding risk is sky high, you switch her to intravenous unfractionated heparin. It's a real lifesaver because its shorter half-life gives you total control, and you can completely reverse it with protamine sulfate if things go south. Finally, we arrive at Phase 5, postnatal anticoagulation care. The postnatal period actually represents the highest relative risk window for thromboembolism. We're talking roughly a 20-fold increase. So we need a rock-solid exit strategy. The first half of this golden rule is the number 6. Anticoagulant therapy must be continued for a minimum of 6 weeks postnatally for literally all patients treated for acute VTE in pregnancy. No exceptions. And here is the critical second half of that rule, the number 3. Treatment must continue until at least 3 months of continuous therapeutic anticoagulation has been given in total. So it's 6 weeks postnatally and a minimum of 3 months total. For example, if she got a clot at 38 weeks, those 6 weeks postpartum wouldn't mathematically add up to 3 months, right? So you'd have to keep treating her until she officially hits that 3-month mark. Postnatally, women finally get a choice. They can stick with the LMWH injections, or they can switch to an oral anticoagulant like warfarin. But a quick heads up, if you're switching to warfarin, avoid it until at least the 5th day postpartum to prevent early bleeding complications, and delay it even longer if there's an increased risk of postpartum hemorrhage. And you can absolutely reassure the new mom that neither heparin nor warfarin is contraindicated in breastfeeding. They are perfectly safe. Watch out for this classic exam trap. Post-treatment thrombophilia testing is only recommended if it's going to actually change her future management. Routine screening won't alter the duration or intensity of the acute treatment she's already finishing up. So hold off on those blood tests unless the results will actively dictate thromboprophylaxis in her next pregnancy. All right, let's wrap this up with your absolute high-yield MRCOG takeaways. 1, never use D-dimer in pregnancy. 2, perfectly contrast those VQ scan and CTPA risks for the mother and baby. 3, LMWH initial dose is always based on booking weight. 4, stop LMWH exactly 24 hours before planned delivery. And 5, treat for at least 6 weeks postpartum and 3 months total. Lock those 5 rules in and you'll be in incredible shape. I'm going to leave you with a quick clinical scenario to test your recall. A patient on LMWH presents at 38 weeks in spontaneous established labor. What is your immediate clinical advice regarding her next dose? Think about the safety profile we discussed, the rules for regional anesthesia, and how you'd manage her right this second. Review the guideline, get these timelines straight in your head, and you will absolutely crush this topic on the exam. Thanks so much for going through this explainer with me.